This episode of the Capsule in Conversation is brought to you by Harrogate Springwater. Famous for its waters since 1571, Harrogate is Britain's premium natural source water. Hello all! You are listening to the Capsule in Conversation podcast. I'm Natalie Anderson, and today I'm joined by one of the nation's favourite TV doctors, Dr Zoe Williams, to talk motherhood, medicine and wellbeing management. So take a minute and get ready to join us in our conversation. Hello all, thank you so much for being with us. I am very excited to be joined today by one of the UK's favourite media medics, appearing regularly on our screens on ITV's This Morning and the BBC's Trust Me, I'm a Doctor. She's also a National Advisor for Public Health England and has been named on the Pulse Power 50 list as one of the UK's most influential GPs. She is a sports enthusiast and a once upon a time gladiator. She is the fabulous Dr Zoe Williams. Hi Zoe!
Hi, Natalie. Thank you so much for that. Gosh, you've got a bit of everything in there.
Well, that's it. You're so well-rounded, though. That's the thing. That's what makes you like so amazing and such a Wonder Woman. It's an absolute pleasure to have you with me, because I do know you are a very busy lady. You are juggling life as an actual GP. You know, you're not just a doctor that we see on the telly. You're an actual GP, and also, you know, your TV work. But being a mummy to your little boy, Lisbon.
Yeah.
How are you finding it?
I mean, he's 9 months now, and I think I'm in that bit where it's suddenly got a whole lot easier. He's a little bit more independent. He's sleeping through the night most of the time. And yeah, but I tell you what, those first few weeks and months are hard work, aren't they? Nobody prepares you for that.
Really hard work. And yeah, I don't think anything can prepare you for it. And you think you are prepared, especially when you've got like a job like yourself, you know, where you do have to be very organised, kind of on it and also on call. You think you'd be really well prepared. But I think just all of us, everyone that goes into motherhood is like, what just happened?
I know. And I think I probably was as well prepared as I could be. I think obviously being a doctor, it gives me a lot of additional knowledge, but you know, I've wanted a baby for a long time, and you know, only met my partner a couple of years ago, and prior to that I'd frozen my eggs and was considering going it alone to have a baby. So yeah, I was definitely ready, but still I wasn't ready.
Yeah. And, you know, talking about that journey that you had there with, you know, having Lisbon, and something that really bothers me, because I really want to have another child at some point. And you know what really upsets me is being called a geriatric mum. Because technically that is correct, isn't it, for our age group? What do you think about that term?
It's just so old-fashioned, and it needs to change. And I think it is. I think they're trying to, people who work within the field of obstetrics and gynecology, I think are trying to change that term and use it less, because it's just so outdated, isn't it? So even if they said and even if they said older, it would be better than geriatric. I don't particularly like that. A mature, I mean, I don't like that either. Also, I think, you know, that cut off of 35, you being considered geriatric above the age of 35, you know, nowadays having a baby above the age of 35 is just the norm, isn't it? And I understand that once you reach the age of 40, your pregnancy automatically becomes slightly higher risk, because there is a higher risk of certain complications. That's fair enough. But, you know, let's come up with a term that is fair and that's kind and nice. They should just do a round table with some mums who were pregnant above that age, and, you know, put our heads together and a majority vote and put a new name on it.
Because as you say, you know, it's kind of like, especially if your lifestyle is active and healthy, and, you know, we will go into that quite a lot in a bit, which is kind of why I really wanted to speak to you, because I know that that's your area. That's something that you're very passionate about, is kind of helping people help themselves, really. So, you know, and if you are kind of do have an active lifestyle and you do look after yourself, there should be no problems really why you can't have a baby and you can't get pregnant later on. Obviously, there are different complications for different women. There's, things that conditions that are hereditary or things that might happen, other factors. But if by and large you are looking after yourself, you should be absolutely fine and have a normal pregnancy without being labelled or being made to feel afraid that past 35 that you can't have a baby. Because I think also that puts a lot of pressure on women to find somebody. I was having a conversation just recently with another really lovely lady on the podcast who said, I was getting really nervous. I got to my early 30s and I'd not met the right person. Yeah. And that does put pressure on people's relationships, doesn't it?
It does. And I felt that pressure because when I was 34 when I came out of a long-term relationship. And I always knew I wanted to be a mum. And I felt that pressure. And really every relationship I then had from that point forward, right from the get-go, the thing in the forefront of my mind is, when do I have that conversation? Because I don't want to waste time in a relationship at my age if somebody isn't on the same page. And I don't want to rush into it, but if the end goal for them isn't the same as the end goal for me, which is to be a family, then I can't be wasting my time. But just, I had a few thoughts on what you said there, and you're absolutely right, because you can think of, we all have a chronological age, which is based on the date that we were born. But we also have a biological age, and depending on how you've lived your life, depending on your genetics, actually, which you either get you're dealt a good hand or not, but based on your genetics, but also how we live our lives, your actual biological age might not necessarily fit with your chronological age. And one of my big frustrations, it's something that I've talked about a little bit, and I think at some point I'll talk about more, is because I was over the threshold of 40. I was 41. I turned 41 during my pregnancy with Lisbon. I was deemed to be at higher risk because of that. And there was a lot of pressure put on me by the doctors to be induced before my due date. And I was kind of pretty much told that, they'd let me go to my due date, but not a day over, and I had to be induced. And I had a doula through my pregnancy and during, and I'm so grateful I did, because she really helped me. Even though I'm a doctor, I'm so privileged that I can look at the data, look at the research and understand it. But she helped me look at it, and that the evidence, well, there isn't any evidence really necessarily to say that was the right thing for me to do. And I never reached my due date, which was a good thing. But I'd sort of prepared my pitch to the doctor, because I agreed to go in on my due date to have a conversation at least. And I prepared my pitch, and it was, if you had 139-year-old women in front of you who are your patients who are, due to give birth, and you will look at their biological ages and put me somewhere within that mix, where would I fall? And I think it's fair to say I would estimate that I would fall probably in the lower, I would fall as healthier biologically than at least half of those women. So then my next pitch to the doctor was, would it be fair then to treat me the same as you would a 39-year-old? And that would mean you wouldn't be putting pressure on me to be induced. And that's me with being a doctor, speaking to another doctor, trying to come up with ways. And I think there's a huge amount of pressure on women to sometimes, when it comes to having a baby, make certain options based on age or other characteristics, because of sometimes just one study that might have been done in the past.
I feel like I'm quite a young person, I'm 41 this year, and I feel in myself not much different to how I was in my early 30s. I don't, I can still run the same, like I used to be able to, give or take a couple of seconds. I can still lift the same weight. I still am capable of doing the same thing. So physically, I feel okay. I don't feel like I've hit a wall or anything, and I know like my own body is telling me that I'm okay. Sometimes I think I might be veering into that perimenopausal kind of age bracket with certain other things like mood swings or whatever, but I still think the physicality of my body is capable of certain things. And so, as you say, to be labelled as such, it feels uncomfortable, and it does make you worry, and it does make you think, oh my God, I shouldn't be doing this, or what if, and you put so much pressure on yourselves. But I think that's because of the labels that exist, and we're not being treated individually, looking at one person. It's just across the board, which I think, as you say, later on we probably need to push for change on that, really, just because of the way as a society we're moving, where women are waiting to have babies later, aren't they?
Yeah, and the same would apply to actually somebody with somebody's BMI. You could have an athlete who is carrying a lot of muscle on their body, who actually has quite low body fat, or actually carries the body fat in healthy places, so under the skin on their arms and legs rather than around the middle. And if that person's BMI at the start of their pregnancy was over 30, even though they might be a really healthy person, the same would apply to them. So we definitely, we do need to look at people as individuals. But I will add that when it comes to fertility, we are living longer lives, we're living healthier lives. So, it used to be that you'd think of a 70-year-old as somebody who would look old and have a walking stick, whereas now, I've got 70-year-olds come along to park run and they run 5K quicker than me. So we are younger, but sadly, the one bit of our anatomy that hasn't changed is our ovaries. So the age at which we enter menopause, sadly, isn't necessarily complying with the other changes in our lifestyles. And I think that because we are leaving it late, we know that 1 in 7 couples actually have fertility issues. It's much more common than we think. And we all know somebody who's been struggling. And I've got friends who have gone into menopause in their late 30s, had early menopause. It's not that uncommon. So I think my advice, to people out there who are thinking that they really do want to have a family, they really want to have children, and if they're in their 30s and that's a bit of a concern, would be to get a fertility MOT. It's not available on the NHS. It's a couple of £100, but it just gives you that extra little bit of information. And it's not a definite, it is an estimation of sort of where you are compared to other people for your age, but it just gives you that extra bit of information. So I had my fertility MOT at the age of 37, and it involves a blood test and a scan to look at your ovaries, and also just check the health of your womb and that type of thing. And I remember being told, well, you're just a little bit below average for your age. And I was like, I've never been below average for my age for anything. But that was where my fertility was, and likely still where my fertility is. So I'm so lucky and so blessed to have conceived naturally with Lisbon, but we are now having the conversation of, do we try to have another baby? It might not happen, it might be too late, but if we do want to give it a go, we definitely shouldn't be hanging around. I'm going to be 42 in April, so I'll be very, very lucky if we can conceive naturally. But it's the question that the debate we keep having at the moment.
Yeah, and I totally understand that, because we're in the same boat. Like, we keep having that same conversation, and and again, it's because you feel so in every other part of your body, you feel you're like healthy and happy and kind of fit and everything. But as you say quite rightly, our fertility isn't necessarily following that pattern.
Exactly.
And now that obviously you do have Lisbon, you are such a hands-on mum. One of the things I found really interesting when I was doing some research on you was just how you were feeling about being a doctor, especially a doctor in the public eye, and a mother, and how people would possibly expect you to know everything, and yet you're just the same new mum as everyone else. I mean, just talk to me about that experience.
Yeah, well, you're absolutely right. I think people think as a doctor, you know everything. And of course, I've seen lots of patients come to me with their babies when they're worried that something is wrong. And as doctors, as GPs, we're very good at identifying when something is wrong and knowing what to do about it, whether that is to give medicine or, to give advice or to refer to somebody who knows more than we do. What we don't learn and what we're not very good at is all the stuff that is medically fine and normal, because people don't bring their babies to us with the normal stuff. They go elsewhere. They might speak to their midwife or their health visitor, and we're not actually experts in the normal baby. So all the usual stuff, I've been doing it for the first time too. I remember when Stuart's mum explained to me a couple of weeks in that when you put a nappy on the baby, you have to turn the frills outwards. Well, I didn't know that. I don't teach you that in medical school. So that's why he was having leaky nappies. And you know, even down to the little things like learning all the techniques to wind a baby, and all that stuff was new to me as a mum. But you're right, I think the expectation of me is to know it all and to do it perfectly, and there's no such thing. One of my best friends just had a baby a couple of weeks ago, and she keeps, you know, as we do, what's the right way for this, what's that? There isn't a right way. You just have to find the way, and it's just winging it, isn't it? Every day is just winging it. I can't believe that my breast pump had 50 pages of instructions, and Lisbon came with none. Especially, we had him at home as well, so we didn't even have, you know, that overnight bit of support. So yeah, it's but there is pressure with Instagram, because there's a couple of times.
I was just going to ask you that, you know, pressure with Instagram. People are very vocal on Instagram, and especially when it comes to children. Yes. Everybody thinks they can say anything about anything. I mean, what's your experience in that area? I
just feel like I'm always constantly having to make sure that I'm stating what perhaps the guidelines are. If there's anything I'm doing with my baby that is outside of those guidelines, and of course there are some things that are, because that's what guidelines are there for. They're to guide you. They're not the rules. It's not like wearing a seat, you know, you have to put your baby in a car seat. That is the law, but you don't have to you know, wean your birthday on their 6-month birthday. That is a guideline. But there's been a few times when Stuart will be like, oh, that's a cute picture, let me take a picture. And then I'm like, I can't post that because that's in the background. Or, you know, it'll be of Lisbon on his changing mat that's on top of his shelves. And I'll have stood back and in, you know, half a metre to take a picture. Now, well, I can't post that because if there's not a hand physically on him, somebody's going to say, you know, you left him on his... The other day I was putting him in the car. We've just got an electric car, so I'd done some content and posted that on Instagram, and somebody was criticising, we live on a cul-de-sac, quiet road, somebody was criticising me for putting him in the car, not on the curbside, on the open side. And it's just, you know, I just ignore it. The mum shaming.
It is. There's a lot of pressure. I remember when I was working at Emmerdale, that's when I just had Fred then. That's when I felt the most vulnerable, and I felt so under pressure and paranoid around, like, even when we went for lunch somewhere and if I was feeding Fred, I felt like everybody's eyes were on me. I'm sure they weren't, but I felt like they were, and I would struggle. And when Freddie was crying, I'd start to want to cry because I'd be thinking, I can't control the baby, and they're all looking at me and they're going, that's her. And it was a really difficult time. And again, for you being a doctor, I expect you do have that tenfold.
Yeah, and I think when you're in the public eye, and you might be out in the restaurant with your family, and, you know, of course, we accept when we choose to work in the public eye. So we accept that we will get some attention from the public. And most people, in my experience, doing what I do, are usually very polite. They might, you know, just want a selfie or want to say a few words or just acknowledge that they recognise who I am. But I think when you've just had a baby, or, you know, it might be when you're having an argument with your partner or you're having an intimate conversation, there are times when you don't really want that, but I think people feel that they have a right to comment and to watch and to judge because you're in the public eye. And it's a tricky one because we've kind of opened ourselves up to it on the one hand, and obviously with Instagram we're choosing to put content out there, but people will judge us more than they would somebody else, a friend. And I think it partly depends what you do as well. I'm sure you have a different experience to what I have. And then at the other end of the spectrum, I mean, I worked with Shauna Phillips the year before last when we did the Real Full Monty together. And obviously she came into fame through Love Island. And she used to show me, I mean, some of the abuse, it was disgusting. And for some reason, people feel that because of the way in which she came to fame, they have a right to comment on her appearance and what they think about her as a person. I'm sure that doing what we do, we're somewhat protected from that, and probably the people that follow us. But yeah, it is a funny one, isn't it? Because people don't know where to draw the line.
They don't know where to draw the line, and I think it does as a new mum. I think it can be difficult to you naturally will make mistakes, as you said, you can't help it. You're learning as you go.
And
Nobody
that's
gets nobody gets the handbook, do they? But then making those mistakes in front of people does cause anxiety and, pressure. Moving just onto your actual job as a GP, and as a doctor, one of the areas, like we said, you are really passionate about is people helping themselves, really, and how to maintain kind of an active lifestyle, a healthy lifestyle, and, like type 2 diabetes, weight management. This is an area for you that you are really passionate about, aren't you? And I watched last night one of your discussions and presentations on physical activity, and there were so many things in that I was like, oh my God, I thought I was really fit and I'm not. And just talk me through, some of the, I know it seems like we would know the benefits of physical activity, but you know so much more. I mean, tell me where we should be at and where we think we're at.
Well, I think when it comes to physical activity, there is a guideline again, and it's a public health guideline. And public health guidelines they're very complex to make, because it's not always, if we take one that's quite easy to talk about, 5 a day fruit and veg, right? Mm-hmm. So our guideline says we should be aiming to eat at least 5 portions of fruit and veg. And the key bit in that is at least, because actually the evidence tells us that for optimal health, we should be eating 10 portions of fruit and veg a day. Now, if you're a family who eat 0 or 1 portions, if the guideline says 10, you're going to switch off and you're just not going to even attempt it. If it says 5, that might be something you can work towards. And actually, for the people who are already eating 5 portions of fruit and veg a day, public health, we're not really interested in getting you to be at optimal health. We're interested in helping people with the lowest level of health improve their health. So guidelines are not always set at the optimal level. They're set they're carefully selected to be where you can get the majority of the benefit, but also they must be achievable for those who are our target audience. So when it comes to physical activity, there's a few different bits to the physical activity guideline. At the top, it says muscle strengthening exercise. We should be aiming to do that at least twice a week. It doesn't have to be in a gym lifting weights. That could be gardening, it could be dancing, it could be anything that might make you muscles feel like they've worked hard the next day. And then the next bit is 150 minutes of moderate intensity exercise per week, which I bet you do, because people then think, oh, that means I have to run or be in the gym for 150 minutes. That's not the case. It's anything counts, as long as it means that moderate intensity means your body feels warmer, you're aware of your heart beating faster, and you're a little bit out of breath, but at the rate you could still have a conversation. For someone like probably you or me, who's got a reasonable level of fitness, that's probably a brisk walk, like rushing a little bit, walking to get to the tube station.
Okay, I feel a bit better.
Whereas for somebody who, has COPD or is very immobile usually, that might be a really gentle walk around the block that might create those changes in their body. So 150 minutes, which equates to about 22 minutes a day. So you can think of it as 2 10-minute brisk walks every day, and you would reach that target without even going to the gym. And then the final bit is around balance and coordination activities for people for older adults. And that's about reducing falls, because we lose muscle once we get older as well. So it's maintaining the muscle. And then the final bit is reducing sedentary behavior. That's probably the one that's worse for most of us. Most of us spend 8 to 9 hours a day sat on our bums like we are now. So shall we stand up for a second?
Yes.
Let's stand up, have a little stretch. We're doing it. Everybody listening, you've been sat down. We've been talking for 20 minutes now. So every 20 minutes, if you can stand up and just even have a stretch and just activate your muscles, that benefits your body in so many different ways, including your metabolism, including how your body deals with insulin and glucose and those types of things. So that's the physical activity guidelines, and it's quite complex, but the underlying thing, the most important message within all of it, is that whatever you're doing today, if you want to improve your health, if you can add on any additional bit of movement, whether that's a walk around the block once a week, whether it's every time the ads are on, standing up and sitting down and doing that, which is a strength exercise, anything you can do additionally will give you health benefits. So wherever you're starting from, if you are doing someone who's doing very, very little, then doing an extra 10 minutes a week will give you health benefit. Whereas if you're somebody who's already, go to the gym 3 times a week and cycles to work and back, doing more exercise is not going to benefit your health that much. The less you're doing, little bits make a big difference.
I think that's the thing. I think, you know, when I started running my business alongside my work, I ended up sitting down for longer periods of time, and I would go, oh my God, the day is gone. And for somebody who's like been on tour and, you know, used to just burning calories, once I was in my work and writing things up, I would find that hours had gone. And then over like the last couple of years, I'd say that I am much better now because I'm more aware of it with this kind of work that I'm doing. But it's so easy to fall into that trap of sitting at a desk and typing away and then eating a sandwich whilst you sat down and not getting up. And it's just making sure that you do have those reminders of, you know, even now you've just said it then, like 2 10-minute brisk walks a day. That could be the school run and back.
Exactly. Instead of jumping in the car, the number of car journeys that are under 2 miles, I can't remember the statistic, but it's huge numbers, and those could be walked or cycled or scootered if you know the children can have a scooter. So those are the perfect ways to get in those extra minutes, and they really do add up if you're doing it 5 times a week or 10 times a week if you're doing it both directions on the school run.
And it's so important because, you know, the health benefits, but also the well-being benefits in terms of your mind as well. And this is kind of another area that I wanted to talk to you about was the social prescribing. See, I'd never heard of this term before, but actually when I listened into kind of what some of it was about, I was like, yes, this is so helpful, because not everybody now, especially in this modern day, wants to rely on taking a pill to kind of feel better. Just talk to me a little bit more about social prescribing and what it actually is.
So social prescribing is something that has been around since the start of time, really. In fact, if we go back many years ago, doctors didn't have a lot of medicines and a lot of surgical techniques and a lot of the gadgets that we have now. They really kind of had antibiotics, which were very helpful, social prescriptions, and I'll come on to what they are, and they had surgery to treat emergency type things. Nowadays, it's kind of like we've gone full circle, because we've got this incredible world of modern medicine where we have all these exceptional drugs. You know, we can even hack into our own genetics now to make ourselves better. And we've got incredible surgical techniques, robotic techniques. And it's like we've forgotten about the basics. And we've got to a point where we will prescribe a pill for, let's take mild to moderate depression, for example. We might prescribe a pill when actually the research tells us that regular exercise can be as effective as an antidepressant for mild to moderate depression. And then talking therapy, all 3 of those different options for treatment can be as effective as each other. And actually a patient can have all 3. And that's one way to optimize their treatment if there's somebody who wants to go down the path of doing all 3. So there's now been a shift back towards, actually, how can we make sure that we're not forgetting about the basics of social prescribing? So exercise is a great type of a social prescription, something like Park Run, which most people, if you haven't heard of, check it out. Park Run happens on a Sunday morning in parks across the country, and actually in a lot of countries in Europe now. Same time every week, thousands of people out in the parks, running a 5K, jogging a 5K, or walking a 5K, or volunteering, stewarding, or actually just going along and spectating. You can get involved in any way you want. Another idea of a social prescription would be singing for dementia. So people who have dementia, the part of the brain that recognizes music is often well preserved in dementia. So even people with quite advanced dementia, if you can get them together and play songs that they would recognize from their youth, it can be really uplifting, and they can often remember and sing along. Singing for asthma and COPD as well, training your lungs. So these are all types of things that it's linking, rather than giving the person a drug. Sometimes people need the drug, it might be in addition to, it's engaging them within their local community into services, resources, activities and groups of things that are already happening that can benefit their health. And we now have the Academy of Social Prescribing that's been running for a few years. It's got great leadership, and we're trying to make sure that across general practice and also hospitals as well, in secondary care, we're not forgetting about the benefits of the social prescription, and that's something that's available to patients alongside medication and surgery.
Because it's really important, isn't it? You know, like that connection. I think, you know, something that we talk a lot about here at the Capsule is that sense of connection, sense of belonging, sense of being part of something has such a huge effect on your confidence, on your overall well-being. Can totally release endorphins that make you feel better. So you're getting all that interaction, that social interaction that, you know, obviously the last 2 years, a lot of people have not had. So actually getting people out into those communities, and I know you've got your own company in the community. Yes. Is that right? The CIC, yes.
So Fit for Life, yes.
That's it, Fit for Life, which is about encouraging young women and young girls to kind of get more physically active. Just tell me a little bit more about that.
So you're right. So Fit for Life is a community interest company, so it's a non-profit.
That's it.
and our original, so Dawn, who's my co-director, we originally set this up to support girls, usually 13 to 14-year-old girls, which is where we see a really steep decline in physical activity levels, encourage them to be active by going into areas usually of deprivation, and working with these young people to co-create, and that's the key bit of what we do, co-create physical activity programs with them rather than providing physical activity programs for them. So that was our focus at the start, but over the years it's somewhat shifted, because we recognise that there was a particular group of children and young people for whom they don't seem to be well supported, and for whom sport and physical activity we thought could make the biggest difference. So we largely now work with young people in pupil referral units, so children who've been permanently excluded from school. Some of the statistics are heartbreaking. Children that usually end up being excluded from school often have very difficult backgrounds at home. They're more likely to have learning difficulty, they're more likely to have mental health problems, and sometimes their teacher and their school might be the only sort of safe place and trusted adult that they have a connection with. So when they're excluded, you know, that can often be the final the piece of straw that breaks the camel's back, and they can be really vulnerable and susceptible to things like gangs and you know, criminal activity. So we work with predominantly now with people in pupil referral units. And the other thing is they have so much potential. Like they're often super smart and savvy, but they just need someone to see that potential. So we recognise that sport and physical activity, number one, is a really useful vehicle because it's something that they feel comfortable with and happy to engage with. Can be more challenging with girls, but we seem to be getting around that as well. But the kind of the final result for us really is to raise these young people's aspirations, give them confidence, improve their self-esteem, in the hope that it will help them go on to a more productive path than what they might otherwise end up being subjected to.
And why do you think, particularly with the girls, that you're seeing such a steep decline?
So I've done a lot of work with Public Health England, developing training and delivering educational content to GPs and other healthcare professionals about physical activity and incorporating it into our clinical practice. And there's one statistic that used to be in our presentation that always just grated on me. As a girl myself who's always been active, and I attribute so much of my success to sport and physical activity in many different ways. This statistic was that between the ages of 8 and 12, 23% of girls are active enough for good health. So in order to be healthy, children need to do 60 minutes a day of movement and exercise. So only 23% of girls in that age group are achieving that. By the time they get to the age of 13 to 15, that drops down to 9%.
Oh my goodness, that's awful.
And there are lots of reasons why. There was a paper just came out last week, actually, detailing some of the reasons why. It's because they're self-conscious. They're self-conscious about their bodies. They don't want to wear the certain school uniforms that they might need to wear for PE. Fear of being judged. Remember that age, you're so self-conscious. And often it's the sports that are being offered to young people in school they don't want to do. One of my good friends, Kat, who I played county level rugby with in the end, she was a great athlete. She never did PE at school. She'd come up with an excuse every time because she was self-conscious. Yet later in life, she came to rugby and turned out to be an incredible athlete. So there are lots of girls, and there were lots of my friends who've developed this negative relationship with sport and physical activity at school because of the way in which it was delivered. And that stays with them. They're like, oh, I should go to the gym. Oh, I have to do this, rather than seeing it as a positive thing that they're able to do. So the way we work differently is we go in and we try and understand the reasons why they're not engaging. And we just say, it's really simple. We say, an example would be, we did some work with a group of girls at school in Essex. And this school, it's in a village proud area, but it's an incredible school. They've got great sport facilities, including like a pretty smart gym. And we said to the girls, would you ever use the gym? They're like, no way. Why not? Because there's always boys in there. We're like, is there anything, is there any circumstance under which you would use it? They were like, well, if it was after school when everyone else has gone home, and it was girls only, we'd love to use it. Like, right, let's get your teacher over. They asked their teacher, she said, which day that we could do that one day a week, which day of the week. They agreed on Wednesday, and it happened. Simple as that. It's simple as letting the children come up with the solutions to their own problems and then enabling them. And how empowering is that then? Also, we were working with a group of girls who weren't interested in sport and physical activity. They were able to go back to their peers, their girls, and say, we're responsible for this. We've set this up. We're the leaders. We're the role models. And all of a sudden, they've gone from not engaging to sport and physical activity to being leaders. And that's kind of the method.
I mean, it's like when you're saying that, then you're like, it's so worrying and so infuriating, because then you look at statistics to say like how many you've got. I think it's 1 in 7 children, it was on the news last night, were obese, which was a worry, because again, we're not helping our children from right at the beginning, are we? Like, we've really got to get in there at the beginning to help young people be healthier adults, to have better lifestyles, to go on and live healthier lives where they can actively be part of the community. And it really does start at that level. And if we're, you're 9% only of girls at that age group taking part in any form of activity, we were lucky because we went to a performing arts school, me and my friends, and they would substitute PE for dance. Yes. So we got to do our dance classes. And for me, that is always my go-to now. Whenever I'm like, I need some kind of activity, I'm like, oh, I'm just going to put some music on and dance in the kitchen with like my weights or whatever. But it's my go-to that makes me feel good. Because I wasn't particularly sporty as a child. I didn't really like it, but I loved dancing and I loved being with my friends and finding that kind of social activity or group that we can help young women with, and young men as well, but getting in at that level, because we are seeing so many problems now, aren't we, with people really struggling to manage their weight, really, really struggling. And again, that's another area that you're really passionate about, is helping people in that way. Just tell me a little bit more about the work you're doing in that area.
So how I sort of came to being passionate about supporting people who are living with obesity came from my own naivety. So when I was a medical student and when I was a trainee GP, I've always been passionate about exercise and, helping people to be more healthy through exercise. And I thought back then, if we can just get people to do a bit more exercise, then this obesity problem will go away. And I didn't think I could solve it on a national problem, but I thought for my patients. So that's kind of where it came from, was the naivety of me thinking it was that simple, which kind of, it wasn't working, and led me to understand it on a deeper level. And actually, because I was interested in it, it really started because all my colleagues would send patients to me when they were looking for solutions to help them with their weight. So I started to learn about it, and I actually joined, I was just a GP trainee when I joined the National Obesity Forum, and started going to conferences and engaging with other professionals who were working in that space. And it soon became apparent that obesity is a really complex disease, and we don't tend to think of it as a disease. I was on this morning, actually, just today, talking about this. We don't tend to think of it as a disease, but actually it is. It's really complex. There are over 100 different contributing causes, and about 70% of the cause of obesity is down to our genetics as an individual. Now, if any other disease was 70% of the cause of it was genetic, we wouldn't have any qualms about whether or not we call it a disease. It's a disease. And that's the truth for obesity. And the other 30% is largely due to your social circumstances and privilege. So we know, going back to childhood obesity, which sometimes I use as an example because nobody's going to say that a 7-year-old child chose to be obese, or, that it's simple or that it's their fault. But where I work in Southwark, which is a borough in London, if you live at the start of this particular bus route, you have versus the end of the bus route. If you're a child living at the end of the bus route in the same borough in London, your risk of having obesity as a child is double the children at the start. You can also expect to live 8 years less. Your life expectancy to be 8 years less. And this is largely due to socioeconomic factors. So, you know, how rich you are, what the high street looks like where you live, if you can afford to eat certain types of food, if you have the time as a family to invest in lifestyle, and also your health literacy. So, you know, if you understand what fiber is, and if you're able to cook, if you have the resources to cook. So I have patients who, you know, live in accommodation where they're sharing it with other families. They actually don't have access to an oven. They only have a microwave. So that's the reality for some people. So obesity is complex. It's complex biologically, and it's also complex socially. And until we recognize it as a disease and stop blaming individuals, bearing in mind more than 1 in 4 adults in this country are living with obesity. So you can't say all those people, a quarter of us are just lazy and choose to have it. It's just not right. We're not really going to make progress in solving what is a really serious epidemic.
And what progress is being made? Like, obviously there are people like you know, championing kind of like, okay, we need to look at this and have it labelled differently. What things are being done to make a change? Because it is a really big problem. And as you say, it's not nice when people are labelled lazy or, you know, kind of no motivation, or they're looked down on, because it exacerbates the problem. So
it does.
What work is being done, and what can we do actually as the general public to help?
Yeah, I think on an individual level, I think, you know, what you described there was what we call weight bias or weight prejudice or weight discrimination, and it's been built into us throughout our lives that we will perceive people differently based on their body weight. If you think about the Roald Dahl books, the baddie is always somebody who's in a bigger body. If you think about the movies we grew up with as children in the 80s, you know, the bad kid was the bully, would always be a child in a bigger body. So this has subconsciously been drilled into us. So we first of all need to recognize our own bias and make sure that we're not treating people any differently or unfairly because of their body size. It's the same as racism. You know, we shouldn't treat people differently because they have a different skin color or they have a different sexuality to us. And the same is true for body size and body weight. So that's something we can all do to change social perception. And then, you know, once we start to tap into that bias and eliminate it, we need levels much higher than us to eliminate it as well. So that's government, that's the NHS. Obesity services are not funded in the same way as, let's say, rheumatoid arthritis services, because there's still this idea that it's a choice and there's blame and the individual is responsible. Only about 40% of the country have access to the full range of weight management services that are recommended by NICE. So that's not fair. And that's another form of discrimination. So things that are being done, I think we all have a responsibility to recognize maybe the bias in ourselves and eliminate that. And it's all about educating ourselves. So a friend of mine, Sarah LeBrock, who is a woman who lives with obesity, has just launched a new charity. It's called All About Obesity. There's loads of information and resources on there. So I think anyone listening to this who themselves is struggling, having issues living with obesity, go on there, have a look, have a read of the resources. You're not alone. You're not on your own. There are so many people going through this. And there's a campaign called Break Free Campaign, which I have to just declare that I was involved in that and I was paid to be involved in that. But if you just search that on Google, there's a load of resources on there as well. There's podcasts. There are some exercise video that my friend Sarah just spoke about that she did to show exercises that people can do irrespective of their body weight. There's information, and there's a little questionnaire that people can ask themselves. And the important thing is, if you are someone who is struggling, if you've been losing weight but you keep regaining it, or, you know, if people make judgments about your lifestyle because of your weight, you do need to seek help from a healthcare professional, because there is support out there. It's not perfect. Healthcare professionals aren't perfect. You might have a bad experience with a healthcare professional, I'm really sorry to say, but that's because they haven't quite got it yet. There's a lot of training out there at the moment for GPs around this topic specifically. But if you do have a bad experience, go back and see someone else, see a nurse instead, see a GP that you know well, ask if there's anyone in your practice who has a special interest in this, go and see a pharmacist. That's another option, and find out what resources and services are available local to you, and get help.
And if you're a parent of a child that you can see, is struggling, what's your advice to the parents as well? Because I've got friends whose children, and they're eating kind of exactly the same thing, but the children are putting on weight. And then there was this awful thing that she told me about one of the children, that they had to either fill in a form or be weighed at school. Something awful that basically declared the child as obese. And my friend was like, I'm just making all the same food. I don't really know what to do. What can you do as a parent?
So and there will be families out there who have multiple children, and they might have two children who, are what we would be deemed to be a healthy weight, and one child who is above a healthy weight. And, it is a lottery of genetics, because they've got the same environment. So what you're referencing there is the child weight measurement program. So this is something that started a few years ago. So the children are weighed at 2 different times within their childhood. And really the purposes of that are because we didn't have the data. We didn't have the data in this country as to what are our childhood obesity rates, because we weren't weighing children. And in order for there to be money invested, it's a chicken and egg. In order for there to be money, so we're weighing children, but there's no help for them. But in order for money to be invested to create those services, we need to identify first, what is the problem? What's the scale of the problem? And then that we can lobby government, and the NHS can allocate resources accordingly. So it's only recent years we've really had that data, which identifies that there really is a very significant problem. In fact, again, I know I often talk about the borough that I work in, because that's where I have the most up to date. But I was looking at this. 23% of children in London have obesity. Can you believe that?
My
23%.
God, that's crazy. That's like a quarter.
Yeah.
That's mad.
So we needed that data to recognise the scale of the issue, so that then the money can be invested, that we can develop services and we can do something about it. But so this child weight measurement program, it's helpful on a national level, but obviously may not always be helpful to the family, because there isn't necessarily the support and resources out there. But I would always say, always go and speak to your GP if you have concerns. You can speak to the school as well. What's available in different areas varies so widely. I know here in Southwark at one point we had specialist school nurses, but they were really working with children right at the extreme end of obesity, because we recognise that, especially when it comes to children, it's so beyond what the child is eating and how much they're moving. Of course, that comes into it, but what we recognise is the majority of these children who have really severe obesity, the root causes go way beyond that, into their mental health and their circumstances at home. And sometimes it was actually the family that needed support in order to create an environment that the child could thrive in better.
And I think that's what's amazing about the work that you're doing, with Fit for Life, because it really does start at those young ages. I've watched so many of those programs that are on Channel 4 and Channel 5 and like Discovery, where they go and meet families with children that are obese, and 9 times out of 10 you see the child is isolated and lonely, and it's that loneliness that makes them become insular and by themselves, and then the parents feel like they're being loving by giving treats, so to speak, and going, oh well, what about this to cheer you up? And as you say, it's the parents that need that education as well about kind of well-being, mental health. Even if a child's not being bullied, so to speak, as we would think of being bullied, it could be online bullying, it could just be purely isolation, it could be getting sucked into the world, the online world, the gaming world, where they've got a connection there, but they're not moving. So what you're doing there, with Fit for Life, of getting in at grassroots level, it's so important. But we as role models and as parents, we need to do our bit, don't we? We need to try as well to kind of spend that time talking to our children, asking them questions how they are, getting to know who their friendship groups are, getting in with them, and not just assuming, but actually getting in those conversations so that we can understand and help, because it's rather than the problem spiraling.
Absolutely. And it's an all systems approach. There isn't any blame or responsibility that lies with parents or school. It's everything around the child. But I think that's right. And parents often ask, what can I do to help though? And I think ignoring the problem it's not going to go away if it's ignored. But one of the things I often advise parents is recognize that the child is actually the expert in this, because normally with a parent and a child, the conversations we have is very much the parent giving information and telling a child and guiding a child. Whereas when it comes to this, and it's other sensitive topics as well, things around mental health, sometimes the best thing a parent can do is have some very cleverly, strategically planned questions, and don't make statements, don't give advice, just ask questions, and then shut the hell up and let your child create a safe space for your child to talk. And they might not talk, but then that's fine. Just say, well, this door is open. I'll ask you again in a couple of weeks. And if you want to talk about it, then you can. And doing it in the car is a really good place, because it takes the intensity out of it. If a child's in the back of a car and you're driving, if you drive, it means there isn't that eye contact. There might be a bit of music on in the background. They've got longer to think before they give their responses. So sometimes having those more difficult conversations in a car can be helpful.
Oh, Zoe, I'm looking at the time and I'm like, there's so much I want to talk to you about. So you'll have to come back and do something else with me that's on women's health as well, because this has been so brilliant and such a fantastic conversation. You've been absolutely brilliant. Thank you.
Thank you. I enjoy talking about it. It's my passion is to talk about these topics and, just get people thinking about them in a slightly different way.
Yeah, because it's really important, because as you said, there's so many things that come out of this. Everything is interlinked, from social prescribing to getting in at grassroots level to that bit of extra activity to fertility. It's all so interlinked. And we can't just, go, oh, you can have a tablet for that or a tablet for that. We've really got to look, haven't we, at the overall picture.
Yeah. Absolutely.
Oh, it's been so brilliant. Well, Zoe can be seen as one of the regular GPs on ITVs this morning on weekdays from 10 till 12:30 p.m. You can also follow her on Instagram at Dr Zoe Williams to keep up with her expert insight into wellbeing and management, weight management, and also follow her journey as a busy working mum to Lisbon. For more wellbeing, fashion and beauty, you can visit us at our website, www.thecapsule.co.uk. You can also catch up with our previous podcast episodes by visiting the In Conversation page and subscribing to any of our podcast channels and YouTube. Please, as always, feel free to leave your rates and reviews. I've absolutely loved seeing some of the fantastic things that you've been saying over this series, so thank you very, very much appreciate it. And you can also drop us a message at our Instagram at Official Capsule if you'd like to put any questions to our future guests or just leave a message. For these current episodes, I will be back next week with another fabulous guest and more conversations of inspiration. So today, all that's left for us to say is goodbye. So it's goodbye from Zoe.
Goodbye.
And goodbye from me. This episode of the Capsule in Conversation was brought to you by Harrogate Spring Water. Bottled at source, Harrogate Spring offers a pure, refreshing taste with a delicate blend of naturally occurring minerals and electrolytes, perfect for healthy hydration.